I'll just be briefing you today about esophagus. Okay. My aim of teaching is not only to make you prepared for your PPG or AIMS or JIPMER. Or I don't mention any special examinations. My aim is to give you complete concept. Okay. I will try to give you the first concept to the last concept. You try to apply it to AIMS or PGI or JIPMER, whatever the exam you are giving. Okay, because I think you have seen the recent Epiphrenic exam, right? Of course, other than all the frauds and all the scams that are going on, Epiphrenic exam was really a difficult one. Okay, unless or until you know all the options, like you have to eliminate each and every option and you have to know the concept in each and every option. The exam was like that. So my style of teaching will be in the format of giving you the complete details from the first to the last. I will concentrate where the MCQs are frequently asked and where are the important topics. Okay, right. I think anyone having any idea about this picture now? Long ago, so long ago, we were in a subject called as embryology. Okay, I think if you have some Indra Beer Singh or any textbook, if you have seen that, some figures, some Greek and Latin figures like this would have appeared. Okay, just forget all these things. Remember one important point, that is esophagus is derived from endoderm. Okay, this is very important point. Why I am telling you is because there are two things. One is mesoderm, endoderm, which are involved in the esophagus formation. Okay, esophagus per se is formed from endoderm, but it is directed by mesoderm. Mesoderm directs endoderm to form esophagus. Okay, but for clarity's sake, remember only endoderm. If at all something related is asked, then we can go. Okay, and the important gene is, have you heard about Hox gene? HOX gene? No? Right. This gene is responsible for the formation of esophagus in the endoderm. Only 2 points. Remember, the endoderm is the point where it gives rise to the esophagus, and the Hox gene, that is a sonic hedgehog gene. Don't remember that. Remember, this Hox gene is responsible for the transformation of endoderm into the formation of esophagus in the embryological state. Okay. Now, let us talk the per se anatomy of the esophagus. The first thing regarding the anatomy is, what is the extent of the esophagus? From where to where? कहाँ से कहाँ तक? उस्मानिया से यहाँ तक, यहाँ से मियापुर तक. Where is the esophagus? What is the extent of esophagus? Please, somebody shoot up your answers. What is the extent of esophagus? Now, let us first talk in terms how do you measure an extent? Whenever you are trying to measure something, the location of something in the body, how do you try to measure? In relation to what? Points. Which points? Anatomical points. More specifically? Okay, fine, vertebral. Like fixed bony points, right? I think you are trying to say that. Fixed bony points. So what are the fixed bony points in relation to the esophagus? What do you have here? What bones are there? Okay, you have vertebra, right? So we define the extent of the esophagus in relation to the vertebra. Okay, so that is, it extends from C6 to T11. I think the figure is clear, where you can see the extent from C6 to T11, where it is piercing the diaphragm, entering the stomach, right? So C6 to T11, this is the extent of the esophagus. And when you degluttate, or when you make a swallow, when you swallow, it moves one part up. Okay, you swallow, there will be a tug on the esophagus and it moves one part up, right? Now, next, so that is regarding the extent. And regarding the parts of esophagus, how many parts are there in esophagus? No, you should be very clear. I have written 4, you are talking about 3. But you are right. Exactly, normally we tell it is 3, the cervical part, the thoracic part and an abdominal part, but a small pharyngeal part will also be there. This is not for your range, this is for SG, that is surgical gastroenterology preparation. Pharyngeal part, they will ask 4, how many parts are there? Of course, the cervical part, okay, it is 5 centimeters. Remember, these lengths are again important. The thoracic part, it is 20 centimeters, and the thoracic part is again divided into 3 areas. That is, one is up to the presence of the left bronchus, and next one is the pulmonary vein, and the last one is of course the diaphragm. Okay, these are the 3 parts of the esophagus, or in particularly to say 4 parts of esophagus. Now, after completing these parts, let us talk in particular about the esophagus narrowings, which is very important for your MCQ parts. Narrowings of esophagus. Any idea where the narrowings of esophagus are present? Right, the first narrowing of the esophagus is UES, that is upper esophageal sphincter. Upper esophageal sphincter is the first narrowing part of the esophagus. The narrowest part in the GIT. Can anyone mention which is the narrowest part in the GIT? Right, don't fear. Okay, I will not beat you, I will not scold you, I will not do anything. Right, be bold, answer to the best of your knowledge, even it is wrong or right, that doesn't matter, because here we are not giving any entrance examination here. Okay, right. So appendix, still I just want some answers from you. Let's be more interactive. Okay, I will try to give the subject from your side. Upper esophageal sphincter. Okay, actually earlier it was thought to be appendix, but upper esophageal sphincter, because of its chronic contracted state, okay, it is the narrowest part in the GIT. Okay, other than this we have 2 narrowings. One is at the junction of aorta and bronchus. Okay, I think you can see the aorta and the bronchus. Again there will be one narrowing, and one narrowing at the lower esophageal sphincter also. Okay, now I think you can see the centimeters are 15, 25 and 40. For whom these 15, 25 and 40 are significant? For not for intubation. Intubation is regarding anesthesia. It's not for intubation. It's for endoscopist. Okay, the one who is performing an endoscopy, he will be having marks on the endoscopy. Okay, like 15, 25 and 40. Okay, and whenever these markings are reached, whenever the endoscopy is passed in the patient, when these markings are reached, then you can identify that the mark is 25 and we are at the level of aorta and bronchus. The mark is 40, we are at the level of lower esophageal sphincter. Okay, the mark is 15, we are at the level of upper esophageal sphincter. Okay, देखो यार, try to speak. Okay, right. So from where we are starting this counting? Counting starts from incisors. Fine, very good. Which incisors? Upper incisors or lower incisors? Upper why? No answer. Why? X, Y, Z. Why? Fixed. Yes, very good. Because lower is mobile. You always to have a fixed point. Okay. So the fixed measuring point is upper incisor, not the lower incisor. This has been again repeatedly asked. Okay. When the lower is again mobile, so you have to always have a fixed point to measure anything. Right. Now, let us move into one more topic, that is the layers of the esophagus. Whenever I talk the term called layers of esophagus, you always should say one term, that is the layer that is absent in the esophagus is. The layer that is absent in esophagus is. This is the standard question, you have to give the standard answer. Serosa, right. Very good. You have, normally what are the layers? intestine? Mucosa, submucosa, muscularis, serosa. Serosa is typically absent in esophagus and also in rectum. Remember, again very important MCQ, serosa is typically absent in esophagus and rectum. Okay, again in the mucosa you have 4 layers: epithelial layer, basement membrane, amnia propria and muscularis mucosa. Okay, the muscles in the mucosa are called as muscularis mucosa, and again submucosa, okay, muscularis propria. Right, we will just have 2 important points regarding the layers and then we will move on. So regarding the epithelium in the mucosa, again very important is the epithelium. Esophagus has 2 types of epithelium. One is in the upper end and one is in the lower end. What is the type of epithelium in the upper part? Stratified, squamous, non-keratinized. Okay, stratified, squamous, non-keratinized epithelium is a characteristic feature of the upper mucosa, whereas it turns into columnar epithelium where at this squamo-columnar junction while entering near the stomach. Okay, that is regarding the epithelium. Now, one important point regarding the submucosa. Think you can make a note: more lymphatics are present and less capillaries are present. What does it signify? Why we are concerned about more lymphatics? Lymphatics से हमें क्या है? What is the relation between us and lymphatics? Metastasis. Very good. Okay, whenever the term cancer or mets comes, lymphatics. So the lymphatic spread or the metastatic spread in a case of esophageal carcinoma is present in which layer? Submucosa. Remember, again I will just revise it in the case of esophageal carcinoma. You have to remember this. Submucosa has got the richest lymphatics and is the main pathway, the fertile spread for the carcinoma. Okay, and of course we have more varices also in the submucosa. Let me take a small deviation from here. I think you all know about portal hypertension. Okay, I think you all know about portal hypertension, right? What is portal hypertension? No, at least that sound should be coming. The drilling sound. Right. Someone. Portal hypertension is? Hypertension in? What is that portal? Vein. Right. Okay. What happens when there is portal hypertension? There will increased portal venous pressure. Right. What happens when there is increased portal venous pressure? Okay. All these things happen. What I am concerned about esophagus. What happens in esophagus? Esophageal varices will come. How? Anastomosis between? Anastomosis between which veins causes esophageal varices? Gastric and? No, portal system. Now let's see portal system. Okay. What is this vein? This is portal vein. This vein is splenic vein, right? Splenic vein will have an anastomosis with left gastric vein. Okay, this is left gastric vein is of systemic circulation. This is of portal circulation. Okay, so this anastomosis causes varices. This anastomosis is typically present at the lower end of the esophagus. So this causes varices here. Okay, what happens in a case of submucosa is, actually what happens in a case of submucosa is, you have muscles. Okay, I'll just explain you about the muscles also. Okay, you have the musculature, that is outer longitudinal and inner circular musculature. Okay, between these muscles there will be protrusion of this submucosal capillaries, submucosal veins. Okay, between the muscles there will be, okay, like jail bars. Okay, between these muscles there will be protrusion of these veins. Okay, that is why you get varices. Otherwise you would have get a small enormous vein, right? Normally varices should be like this, completely enormous. but because of the bars of these muscles, there will be suppressions which causes small varices. Okay, you get these varices because of the anastomosis between splenic vein and left gastric vein. This is very important. Now, let us complete about the muscularis, the last layer also. You have two muscles, outer longitudinal and inner circular muscle. Longitudinal muscle causes, it is long like this. Whenever it contracts, it causes shortening of the esophagus. Circular muscle causes corkscrew shaped appearance of this. Okay. I just want you to make a note of two important points here. One is regarding the Killian's triangle. Okay. And one is regarding the Lemierre's triangle. I think you all know about Killian's dehiscence and Killian's triangle. But one more thing important that you have to know is about the Lemierre's triangle or the Lemierre's dehiscence or the V shape of Lemierre. Okay, just to make a note of this, just remember in case when one is asked, the opposite might be asked. Right. This V shaped area of Lemierre is nothing but the V shape between the circular muscles. Which is outer, which is inner? Outer longitudinal, inner circular muscles. Okay. In the inner circular muscles, there will be a dehiscence. Okay. Just remember, it is the V shaped area of Lemierre is the dehiscence in the inner circular muscle. Okay. Just remember that. That's all. Of course, I think we will be discussing about Killian's dehiscence in detail. Okay. That is the Lemierre's area. Next, we will move on to one more important topic regarding the anatomy of the esophagus only. That is regarding the gastroesophageal junction. All the things regarding the esophagus are related to this GEJ only. That is the gastroesophageal junction is the most important point that you have to identify in a case of esophagus. Because all the adenocarcinomas, refluxes, everything will be occurring here. Right. How to identify this gastroesophageal junction? What is the limit? Boundary kahan hai? Okay. After this line, you will enter that zone. That is esophagus entry and you will enter into the gastric zone. Okay. There are two important indications. One is endoscopically, how you can identify, and one is external identification. Age old days where endoscopy was not available, we have to open the stomach, you have to identify externally. Okay. So nowadays endoscopically you have the Z line. The important identification marker is Z line. Z line is nothing but the squamo-columnar junction. Okay. Squamo-columnar junction is marked by the Z line. Okay. And also you have the rugal folds. Of course, stomach has the rugal folds. The starting of the rugal folds indicate that it is stomach. Okay. Endoscopically you have two important points, Z line and rugal folds. Okay. Whereas in this external field, how to identify is, you will have a GEJ fat pad. I think you can clearly see that. A gastroesophageal junction is marked by a presence of a fat pad, a small amount of omental fat like thing. Okay. A fat pad thing is present there. Okay. And you also have one more important marker, that is a collar of Helvit. Just bear with me regarding the anatomy, is because anatomy of course is dry, hot, humid, whatever. You have to bear with it. Okay. So GEJ, two important endoscopically, Z line and rugal folds, and externally they have a fat pad and also loop of Willis or collar of Helvit. I will just tell you what is this collar of Helvit or loop of Willis is. When in the esophagus you have this outer longitudinal and inner circular muscles, right? The inner circular muscles of esophagus turn into oblique muscles of the stomach. I think you can get that in the diagram. The inner circular muscles of the esophagus turn into oblique muscles on the stomach. Okay, at that oblique muscles, it forms a collar like thing. At the junction, it forms a collar like thing. That is called as a collar of Helvit or a loop of Willis, which marks the junction. Okay, right. Any doubts? Just ask me then and there. Okay. Now, as usual, we have arterial supply, venous supply, lymphatic drainage, and also nerve system. Nothing to worry about it much. I'll just tell you which are the important points. Just remember that. Okay. Again, we will divide cervical, thoracic, and abdominal parts. Okay. Just make a tabulate column like that. Cervical part, the arterial supply is important. That is by the inferior thyroid artery. Heard about this inferior thyroid artery somewhere? Okay. So, inferior thyroid artery, I think the same location, we have this. And thoracic part, we have direct branches from the aorta and the direct branches from the bronchial artery. No need of writing all those things. Just listen. Okay. In the abdominal part, again, inferior phrenic artery, that is near the diaphragm, and the left gastric artery. Just try to have a correlation, that's all. Okay. Remember this cervical part, very important, that is supplied by inferior thyroid artery. That's enough. Next, regarding the venous drainage also, nothing significant, but as usual, basic anatomy, the left side is supplied by, the left side is drained by, and the right side of the esophagus is drained by. These two are important. Azagus and hemiazagus. You have two things. Azagus is present on, this is right side. Please try to see the figure and answer. Okay. Nowadays it is present on right side. Earlier I don't know. Okay. So the azagus on right side and the hemiazagus on left side. Okay. Just this is basic anatomy. Okay. But whenever the examiner is trying to ask you as an MCQ, he will try to make some alterations and difficulties. Okay. Now, I think we discussed about this portal hypertension and lymphatic drainage. One important point again, lymphatic drainage, always whenever in case of carcinoma or like these things, upper 2/3 and lower 1/3 division is okay. Upper 2/3 drains upwards and lower 1/3 drains downwards. Okay, make a division, make a note of the division. Now, nerve supply, I think you all know that, but entering into the nerve supply, I just want to tell you two important points, that is you have mesenous plexus and myenteric plexus. Basic physiology. Okay. Mesenous plexus are present in which layer and myenteric plexus is present in which layer? Mesenous in submucosal, myenteric in? Myenteric in? It is myenteric. That is muscles only. Okay. It is muscularis layer. Okay. Fine. After that, again one more important MCQ area. Just pay some careful attention to this, that's all. Everything is clear. Whenever a question is asked on deglutition, try to deglute and then answer. You will know that. Okay. Put some chocolate in your mouth first, what you will do? Right? That is the thing that we all do. That is elevation of the tongue. Okay. So, first thing in the act of deglutition is elevation of the tongue. This is a frequently asked MCQ in JIPMAR actually. Okay, make a note of this thing. Elevation of the tongue and the posterior movement of the tongue. You want to push the chocolate into your mouth? No, you don't want to push. You want to have some aroma of that. Okay, whenever you are trying to push the bolus of the food, again you have the posterior movement of the tongue. Okay, elevation of the tongue and the posterior movement of the tongue, and all the things elevate. Opening the passage, all the things elevate. That is elevation of the soft palate from upwards to downwards. Elevation of the soft palate, that is here, and the elevation of the hyoid, elevation of the larynx, and the tilting of the epiglottis. Very easy. Actually, this MCQ was asked in an order. You will give 4 options: ABCD, BCAD, CBCD. Okay, all these things. Okay, elevation of don't ask CBCD. Right, and this is very important point. Continuation of the esophagus is not at all required for the act of deglutition or for the nerve stimulation, whatever. You can have esophagus in cuts also. Okay, continuity of the esophagus is not required. This is an important point. Why? Because in the case of esophageal trauma or something like that, Even if there is some nerve damage also, you will not have any deglutition problem actually. Okay, right. Let us talk about sphincters. This is the last anatomical part. Okay, I think we completed the layers, we completed the junctions, we completed the arterial, venous, nerve supply, lymphatics, everything. And let's complete about the sphincters. We have two sphincters, right? Upper esophageal sphincter and lower esophageal sphincter. Right. Upper esophageal sphincter, I think, is the tightest or the narrowest part. Okay. You can see the relaxing pressure also 60 mm of Hg. That is very tight. Even it will not allow the air to pass into it. Okay. That is why it is the narrowest part in the GIT. Even if the air is not passing, then there is nothing much. No other part is as small as that. Okay. Right. And we have lower esophageal sphincter. Lower esophageal sphincter is not an anatomical sphincter. It is just a physiological sphincter. Okay. Whereas the upper esophageal sphincter is an anatomical sphincter. Okay. The length of the upper esophageal sphincter is 5 centimeters. The lower esophagus is also around 5 centimeters. But the important point you have to remember in lower esophageal sphincter is it has got an intra-abdominal part. Lower esophageal sphincter has got two parts, thoracic part and intra-abdominal part. The intra-abdominal part is very important in holding the pressure. Okay. So, if the intra-abdominal part is more, you will have less reflux. If the intra-abdominal part is less, you will have more reflux. Okay. So, the LES is not important. The intra-abdominal part of the LES is the important point. Okay. So, remember this thing again when we are trying to deal with the GERD and all these things, we will be talking about the length of the lower esophageal sphincter, that is especially the intra-abdominal part. Okay. Right. Now, I just revision about that. Whenever you are trying to swallow, there will be relaxation of this upper esophageal sphincter, all these things. Remember this point, the upper esophageal sphincter gets back to its normal pressure when the wave is in the mid-esophagus. When the wave has reached the mid-esophagus, then the upper esophageal sphincter gets back to its normal resting pressure. Upper esophageal sphincter will always be in a tight resting pressure. Okay. When the wave is in the mid-esophagus, again it gets back to its normal position. Now, let us talk about this lower esophageal sphincter also. This lower esophageal sphincter is not actually a sphincter, but it is just guarded by a phrenoesophageal membrane, which is a continuation of this transversalis fascia of abdomen. Okay, don't worry about this, all these Greek and Latin terms. I will just show you the figure so that you can easily remember. Okay, this is the endo-abdominal fascia or the transversalis fascia of the abdomen, which tries and comes and forms the phrenoesophageal membrane or the phrenoesophageal ligament, and thus forms the lower esophageal sphincter. Okay. Any doubts or any difficulty, just ask me now and now. Okay. Simple. The endo-abdominal fascia or the transversalis abdominal fascia surrounds the lower esophageal membrane as the phrenoesophageal ligament, and thus forms some anatomical part. But exactly to say, LES is not anatomical. Right. So, this finishes off all this Greek and Latin. We will move to one important physiological part. Anatomy तो ऐसा ही होता है. Wherever you go, it follows. Okay. And the thing is, whenever you are pursuing for a surgical branch or something like that, you have to know the anatomy. If you know the anatomy, you can do any surgery. Actually, I am a general surgeon. I have been doing all types of surgeries, even gynec surgeries also. Of course, outside you will be doing more gynec surgeries only. You know the anatomy well, you can just cut over whatever you want. Okay, but knowing the anatomy is very important. Think surgery is nothing but cutting, cutting. Two things only surgery. Okay, know where to cut and where to cut. That is to stitch. And you will know the surgery. Very simple. But if you don't know where you are cutting, then that becomes a difficulty. Okay, let us talk about the physiology. 2 points regarding physiology, that is regarding the waves. I think you all know about the waves. We have primary wave, secondary wave and a tertiary wave. Okay, the important point regarding the primary wave is you produce a primary wave. You try to deglutitate or you try to swallow, then voluntarily you produce a primary wave. Okay, when the food is in the esophagus, it tries to produce a secondary wave. Okay, these two things are fine, but tertiary wave, it is an unwanted wave, it is a non-progressive wave and it causes spasms. You find a feeling of stuck in the throat or like this whenever you eat some hard foods like dosa. Sometimes you go for water. Okay, that is because of the tertiary wave. Okay, the dosa wave is tertiary wave where you get a spasm that causes a non-progressive wave and the food will be stuck there. Okay, that is the tertiary wave. That is mainly is responsible for all the spasms and all the nonsense motility disorders. All these things is tertiary wave. Okay, right. And one more important point that has been recently added in Sabiston. I think there are 2 important books, Sabiston and Squats for surgery. Of course, you have to remember the names because they are great people. You have to get their blessings in order to pass in surgery. Okay, right. Respiratory inversion point. Remember this point again recently added. That is the way you have to know about this thing. Recently added, highly vulnerable for MCQ. Okay, respiratory inversion point. Nothing, no difficulty in this. This is very simple. Actually, it is a transition from the intrathoracic to intra-abdominal sphincter. That is, this respiratory inversion point is calculated by doing a manometry. What we do in the manometry is, we will put a tube into the mouth and then slowly drag it. That is, the transducer will be in the abdomen. You will slowly drag it into the thorax. Okay, whenever you are trying to drag this, okay, you have a recording. That is the thing that I have shown here. You have a recording. It is in the abdomen part. First, slowly you are dragging the manometry. It is coming to the esophageal part. Okay, in the gastric part, it is slowly raising. That is, there is a positive deflection. Suddenly, in the intrathoracic part, there is a negative deflection. That is the respiratory inversion point. The positive deflections turning into negative deflections from entering intra-abdominally to intrathoracically. Clear? Intra-abdominally to intrathoracic, positive to negative. That is respiratory inversion point. The inversion of a positive wave to a negative wave when it is traveling from the abdominal part to the thoracic part. That is called as respiratory inversion point. Okay, I don't know what is this slide. Successful people ask better questions and as a result they get better answers. Who are the successful people? No successful. We are all successful. Getting an MBBS seat is always successful. Apart from all those things, more successful, less successful only. Now, I just want to have some more successful people who are going to ask some better questions. Very good. Why the inversion point? Nice. That is simple because in the thoracic region, always there will be negative pressure. Okay. Whenever there is a negative pressure, whenever you are trying to eat also, the food that is present in your mouth gets sucked into the thorax. That is because of the negative pressure. Okay. In the abdomen, you will have a positive pressure that is putting all the pressures on the stomach. Whereas in the thoracic region or in the esophagus, you will have always a negative pressure. So, whenever you are trying to do the manometry, okay, the positive pressure will be turning into negative pressure. That is just simply recording of the pressure, that's all. Okay. It is a simple technique, but that has been recently added. That is why we are discussing it in a larger terms. Okay, respiratory inversion normally occurs that we are measuring by an endoscopy. Okay, by a manometry. That point is called as respiratory inversion point, where the positive was turning into negative. Okay, we have to make a note of that point. That's all. Right. If you don't have many questions, then we will try to move on with any questions, or we will just try to see still any questions from our friends. Now, if there are no questions, just let me ask you some 2 or 3 questions. Okay. So, metastatically, which is the important layer? Wow, right, very good. Next, what is Lemierre's area? Is a defect in which muscle? Circular muscle, right. Which has got the highest pressure in the GIT? Upper esophageal sphincter. Can I know what is the pressure? 16. Nice, very good. All these figures and everything I have got down only from the standard books, Habiston and Squads only. No new figures, no nothing. Just putting the figures from the standard textbooks. Okay, right. I think up to now it is very clear. No doubts, right. Now, let us move on to some important topics, that is regarding the diverticulums. I think you all know about these diverticulums. From here, we will be moving a bit fast because these are the familiar topics. You would be answering, I will be just trying to reciprocate you. Now, what are the types of diverticulums? Read. What are the types of diverticulums? Okay, it is classified based upon anatomical position, based upon whether it is true or false, based upon the pressure. Okay, so anatomical classification is pharyngoesophageal, that is in the upper part, next mid-esophageal and the lower esophageal, that is supradiaphragmatic. Okay, next true or false. What is true, what is false? What is a true diverticulum, what is a false diverticulum? Right, a diverticulum, it is called as true diverticulum when it has got all the layers of the esophagus. So the layer that is present or the layer that is absent in the true diverticulum, mucosa, submucosa, muscularis and serosa. No, I am telling you, listen carefully. True diverticulum is a diverticulum which has got all the layers. Okay. Now, which is the layer that is absent in a true diverticulum? Mucosa, submucosa, muscularis and serosa. Right. Thank you. False diverticulum. Okay. False diverticulum is a diverticulum. Any doubt with that? True diverticulum? Serosa is absent. Silly question only. False diverticulum. False diverticulum is a diverticulum which has got only 1 or 2 layers. Okay. Either the mucosa or the submucosa or the muscularis. Not all. Okay. Right. Traction and pulsion. What do you mean by traction? Traction is pulling only. Pulsion is pushing. Okay. First, let us be clear with our English first. Later, we can be clear. Traction. Okay. So, we will dive to discuss about this diverticulums. Of course, the most important diverticulum discovered by Zenker is the Zenker's diverticulum. Why this Zenker's diverticulum occur? Where this Zenker diverticulum occur? What are the clinical features? How to diagnose? How to treat? Etiology. Okay, say for your exam also, you will be writing the same headings. Whatever the matter you write inside, the headings are the same. Etiology, clinical features. Okay, you have radiology or the diagnosis, and then the treatment. We will discuss everything in the same terminology. So, where is this Zenker diverticulum first? Killian's dehiscence. Okay, now comes the terminology Killian's dehiscence. Where is this Killian's dehiscence present? Right, it is present in a muscle called as inferior constrictor. Inferior constrictor. Okay, now inferior constrictor muscle has got two divisions in it. One is the thyropharyngeus and the other is the cricopharyngeus muscle. Inferior constrictor muscle has got two divisions, the thyropharyngeus and the cricopharyngeus. Okay, fine. So, in between these two, there is a small weakness area which slowly outputs as a diverticulum. why there is a difference or why there is a weakness in this area? What makes a weakness? Actually, there will be no anatomical like this. Actually, everything will be closed, no opening. Why? Even though they are from the same muscle, inferior constrictor, it is supplied by two different nerves. Because of the incoordination between these two nerves, one is pulling, one is pushing. Okay, so there will be a weakness. This thyropharyngeus is supplied by pharyngeal plexus. Thyropharyngeus is supplied by the pharyngeal plexus, whereas this cricopharyngeus is supplied by, I think that you have to know. Cricopharyngeus, recurrent laryngeal nerve. Because of the incoordinates between these two nerve supplies, okay, there will be a weakness in this area that leads to a Killian's dehiscence, which causes a Zenker's diverticulum. Okay, remember the two terms, thyropharyngeus and cricopharyngeus, and the nerve supplies, the pharyngeal plexus and the recurrent laryngeal nerve. Now, what are the clinical features? Why we are concerned if the patient has got Zenker's diverticulum? Clinical features, right? So the most important clinical feature and the most common is dysphagia. Okay, whenever you have a Zenker's diverticulum like this, so I think you can identify this Zenker's diverticulum. This is a radiograph, a barium swallow. You will have two types of radiographs. One is barium swallow and barium meal. Which is thick, which is thin? Actually, both are same. Barium swallow is not different and barium meal is not different. It is because of the constituency. You have a thickness, it will be only lining this part. You will have a thinness, it will easily enter into your stomach. Okay, so barium swallow is used mainly for visualizing the upper parts. Barium meal is used for visualizing the lower parts. Okay, now this is barium swallow. Okay, because we are visualizing the upper part. Think you can see the diverticulum here. This is the esophagus part and the diverticulum outpouching. Right. Now, the most common clinical feature is dysphagia and halitosis. Because of the presence of the food stasis, okay, there will be always a chronic smell because of the stasis. Okay, and also recurrent respiratory infections, aspirations, all these things will be happening. Nowadays we don't see up to that extent. Normally dysphagia the patient will present now. Next, one more important term, boys sign. Okay, exclusively for boys. What is this boys sign? This Zenker's diverticulum normally starts growing posteriorly. Okay, because the Killian's dehiscence is posterior, it starts growing posteriorly and later it assumes one side. Most common is the left lateral side. Okay, you have a small swelling like this here. Whenever you try to press that swelling, you will get a gurgling sound because of the stasis food. Okay, boys sign is gurgling sound on palpation. Okay, gurgling sound on palpation is boys sign. Right. Now, we have identified, we give a barium swallow for the patient. We have identified that it is Zenker's diverticulum. Very good. And now what to do? See, I have told you the basic step in surgery is always cut. Okay. Surgery is just like having your sword. Remove your sword, charge to the patient, cut whatever you like. Okay. But make sure that you always cut his pockets first. Later all you can cut anything. First pockets cut cheste, everything will be clear. Now, what to do for the treatment? Yeah, I am giving you options. Just try to think. Right. The standard treatment for this Zenker's diverticulum is endoscopic Dolman's procedure. Okay, I'll just come to that. Now, this is myotomy. Remember, Cutting a muscle is called as myotomy. Now you have a chronic constricted muscle called as the cricopharyngeus and thyropharyngeus. Okay, because of the chronic contraction of this cricopharyngeus and thyropharyngeus only, there is increasing the pressure of the esophagus, which is outpouching. Try to release this pressure by cutting this cricopharyngeus and thyropharyngeus. Simple. The pressure is relieved. If at all a small diverticulum is present, it goes back to normal position. Okay. Remove the cause. It is treated. That is less than 2 centimeters. You do just a myotomy. That's enough. If at all that is 2 to 5 centimeters, even though you give a cut, it is not treated. Then what you have to do? You have to do an endoscopic Dolman's procedure. An endoscopic Dolman's procedure. Simple. Just have a look here. I will try to do a Dolman's procedure here. Very easy. Whenever you are having a diverticulum like this, put an endoscopy. Try to anastomose these both things. The esophagus will be like this. Finished surgery. This is endoscopic Dolman's procedure. Put an endoscope, try to anastomose the 2 layers. The sac will become continuous. Very simple. Okay, 40,000 only, cost also. Very easy. Okay, right. And if at all you have a large diverticulum, whenever there is something large, there is no option. You have to go for diverticulectomy along with a cricomyotomy so that there would be no recurrences again. Okay, make sure that there will be no recurrences. Put a cricomyotomy, that will relax the pressure so that further also there will be no again protrusion of a diverticulums. Clear? Any doubts regarding Zenker's diverticulum, please let me know. Zenker's diverticulum is very frequently asked question. Okay? No. It is also seen in laryngoscene. Okay. The thing is, Boy's sign is a gurgling sound on palpation. Yes. In Zenker's diverticulum also there will be food and the stasis part. The saliva will be getting accumulated. Whenever you try to press that also, it also gives a gurgling sound. Very good point. It is also seen in laryngoscele actually. But the thing is, Boy's sign is gurgling sound on palpation. Whatever it might give. Okay, there are 2 pipes only. One is the esophagus and one more is the trachea. You get some larynx or the trachea, you get a laryngocele. There will be some accumulation of the saliva which causes gurgling sound. Again, that is also Boy's sign. Okay, I made it more particular that gurgling sound or palpation is called as Boy's sign. Okay, it might be due to anything and you are right with that. Zenker's diverticulum. Anybody want to treat now? Ready? Right. The supply of this cricopharyngeus muscle is nice. Now, the second diverticulum. Okay, that is mid-esophageal diverticulum. That is present at the mid part. Upper part is finished. Now the mid part. Mid-esophageal diverticulum is mostly caused due to the inflammation. Okay. What happens in the mediastinum is you have several structures like lymph nodes. Okay. Supracarinal, infracarinal lymph nodes are there. Whenever these get infected, they cause some fibrosis and pull the esophagus. Okay. This might be most commonly due to tuberculosis. Always tuberculosis in HIV patients, whatever. Okay, histoplasmosis, tuberculosis, mycoplasma, whatever the cause of lymph node fibrosis, which causes traction. Okay, or the mid-esophageal, that causes a mid-esophageal diverticulum. Okay, sometimes it is, majority of times it is asymptomatic, but sometimes it might be symptomatic because of BEF, like TEF. What is TEF? TEF, tracheoesophageal fistula, but we are talking in terms of BEF because it is at the level of bronchi. Okay, trying to be more specific, that's all. Okay, bronchoesophagic fistula. The same thing, tracheoesophageal fistula, the same thing, bronchoesophageal fistula. Okay, right. And again the treatment will be the same, less than 2 centimeters. You will not have any problem here. Okay, because it is just a pull like this. Okay, even though there is a swelling like this, the food can pass easily. So majority of times you can just wait or treat the cause. Okay, don't be over enthusiastic in doing a surgery. Now that is a mid-esophageal diverticulum, and the next is epiphrenic diverticulum or the supradiaphragmatic diverticulum. Okay, pictures very clear, speaks for itself. The mid-esophageal diverticulum and the epiphrenic diverticulum. Okay, the same thing again, epiphrenic diverticulum also. The most common cause is motility disorder. Majority of times motility disorders, they cause vigorous contractions, but the diaphragm will not allow the contractions to pass. It will be holding tight. Okay, so there will be an epiphrenic diverticulum. Okay, and sometimes in Ehlers-Danlos syndrome, trauma, all these things are there. Nothing to worry. Motility disorders, remember, motility disorders mostly cause epiphrenic diverticulum. Okay, again the symptoms and the treatment, everything is the same. Symptoms, again you will not be having many symptoms. If at all, sometimes there will be some dysphagia, asymptomatic majority of times. Treatment again, less than 2 centimeters, wait and watch. More than 2 centimeters, transhiatal diverticulectomy. The approach is just transhiatal because it is epiphrenic. You need not open the thoracic part. Just it is transhiatal diverticulectomy. That's enough. Okay. This is the diverticulum that is present. Now, so that is regarding the diverticulums. Everything is finished regarding diverticulums. Okay. Any doubts? Please, some of our friends, if at all some doubts are there, please shoot out. Okay. Now, Zenker's diverticulum is also called as. Very good. Let us come to you. Zenker's diverticulum is also called as pharyngoesophageal. It belongs to true or false diverticulum. Zenker's diverticulum is a true diverticulum or false diverticulum. Why false? See, I will tell you one secret. Okay, you know why professors they do invent some great things? You know how the technique of inventing great things? I will tell you. You should not tell anyone. Okay, they'll ask questions in the class. You give different answers. That gives us more ideas. We don't even think of that thing sometimes. ऐसे भी हो सकता है. Okay, let us see. Just make a note of it silently. Go home and then do some exercise on that. Okay, that is why we will try to ask some questions. Okay, fine. Where are we? What was that answer? True, false. Okay, fine. Let me tell you what is true and what is false now. What is true diverticulum? Or the layers, right? Zenker's diverticulum was having what layers? Mucosa it was having, submucosa it was having. It was coming in between the muscles. Where is the muscle layer? It was coming in between the muscles. Right? Zenker's diverticulum was present between the thyropharynges and cricopharynges. It was not having the coating of muscular layer. So it is a false diverticulum. Okay. Clear with that? And mid-esophageal and epiphrenic are true because it was traction. It was pulling every layer. Okay, from outside. If at all you want to get a pipe, okay, if you are pulling it from outside, you pull the upper layer. Will it be a diverticulum? No. See here, these are the layers. You pull only one layer, you pull only this layer, the inside esophagus will be normal. If you want to have a diverticulum, all the layers should be pulled. So mid-esophageal and the lower esophageal, it is always a true diverticulum. Okay? Any doubts regarding this? Yeah. In case of diverticulums, you should always concentrate whether it is true or false, pertaining to the only layers that it is having, not the layer which is not having also. Of course, serosa will not be there, but it doesn't indicate that serosa should be there and it should be a true diverticulum. It is not like that. Okay. Serosa is normally absent. Okay. That is another issue. Serosa is normally absent. In the what are the three layers that are present? In the persisting three layers, what are the layers that are present? That is what we have to count for. Okay. Now esophagus is having three layers. If the three layers are present, it is true. If one or two layers are present, it is false. Okay, don't think that serosa was absent, so it was not there, so everything should be false. Okay, this is not mathematics. Right. Okay, let us go to one more topic, that is Lugard's pouch. Okay, Lugard's pouch. Lugard's pouch, just want some break here. We will complete with this Lugard's pouch and then have a small discussion. Right, Lugard's pouch is nothing but whenever there is a small band between the vertebra and the bronchus. Try to visualize, you will be having one vertebra and a bronchus. Okay, in between that the esophagus will be going. Okay, whenever there is a band or a small obstruction, the esophagus will go and take a curve. That pouch is called as Lugard's pouch. Okay, it appears as a curve, as a pouch. That pouch is called as Lugard's pouch. Okay, small pouch like thing, that is called as Lugard's pouch. That is seen because of a band like structure that is present between the bronchi. Which bronchi? Mostly left bronchi and the vertebra. Okay, a band like structure that is present between the left bronchi and the vertebra gives rise to a Lugard's pouch. Lugard's pouch is nothing but a small bend in the esophagus. Okay,